Hello, and welcome to this PrecisCa mini tumor board on breast cancer. My name is Dr. Reshma Matani. I'm a breast medical oncologist at the University of Miami Sylvester Cancer Center, where I co-lead our breast cancer program. It's my pleasure today to be joined by several well-renowned experts in breast cancer, who I'll now ask to introduce themselves. I'll start with Dr. Shah.
Hello, I'm Chirag Shah. I serve as the Director of Breast Radiation Oncology at the Cleveland Clinic.
Hi, I'm Stephen Poplack. I'm a breast radiologist, professor of radiology at Stanford University.
Hi, I'm Monica Morrow. I'm the Chief of Breast Surgery at Memorial Sloan Kettering Cancer Center.
Hi there, I'm Dr. Sarah Hurvitz, Professor of Medicine at the David Geffen School of Medicine at UCLA, where I'm a medical oncologist specializing in breast cancer.
This is a 50-year-old Caucasian woman with a history of stage 1 ER/PR positive, HER2 negative, right breast cancer, treated with lumpectomy, sentinel lymph node biopsy, radiation, and 6 years of tamoxifen, now with a locally advanced right infiltrating lobular carcinoma, grade 3, ER/PR HER2 negative, with contralateral axillary metastases. So the questions were posed are with regards to whether treatment should be given with curative intent, or should the left contralateral axilla be treated. So this patient presented initially presented now to her medical oncologist with new firmness and a decrease in the size of her right breast 13 years out from her initial diagnosis. So recall, this is 13 years after having undergone a lumpectomy, radiation, and hormonal therapy for a tumor in the right breast. She maintains a good performance status, has no medical issues, had menarche at 12, menopause at 49, G2, P2, no use of oral contraceptives, HRT, no toxic habits, and no family history of cancer. On mammography in March of this year, she has diffuse skin thickening, edema, and trabecular coarsening with mass-like areas of shadowing in the right breast, and multifocal disease in the right breast was noted by imaging with diffuse abnormal enhancements spanning a large area by breast MRI, with multiple solid masses in the right breast along with left axillary adenopathy. Dr. Poplack?
Thank you, Dr. Matani. This is an interesting case, so I wanted to show you an example of this phenomenon, which we call the shrinking breast sign. This is not this particular patient, but a patient that I took care of a few years back. And here's a mammogram showing the asymmetrically smaller right breast at the time of presentation. There's a BD in the upper outer quadrant on the right breast, denoting the palpable abnormality. So this is the asymmetry noted. If you go to the next slide, this is the same patient a few years previous, and you can see the symmetry of her breasts. Next slide, please. So this is what we call the shrinking breast sign of invasive or infiltrating lobular carcinoma. It's fairly infrequent. In our literature, it's only been reported a few times. It seems to occur in about 15% of patients who present with an ipsilateral decrease in the size of their involved breast, which may or may not be apparent to the patient. On clinical exam, they have fairly diffuse breast thickening. Interestingly, on imaging, they tend to present with asymmetry and distortion rather than a mass. And the tumor size is much larger with this type of presentation. In one paper, about 6.5 centimeters to 1.5 centimeters to patients presenting with the more focal presentation of invasive lobular carcinoma. And accordingly, the histology is more diffuse. Next slide, please. This is the current patient. This is on the left side, a mammogram of her right breast showing skin thickening and density centrally. She did have previous breast conserving therapy, I believe, so it's unclear whether the skin thickening would be on that basis, based on the mammogram itself, unless there had been an increase over time. The right-hand image is ultrasound showing a small irregular shaped hypoechoic mass with indistinct margins, typical of a breast cancer. Next slide, please. And here's MRI from the current patient. On the right-hand image, you can see her contralateral adenopathy. She's got enlarged, rounded lymph nodes with loss of the normal fatty hilum. And on the left-hand image, you can see the asymmetrically smaller breast, right breast, with enhancement of the skin and non-mass enhancement percolating through her breast, which can be typically seen in this diffuse presentation of invasive lobular. With the skin enhancement, you'd also have to consider, in addition to direct extension into the skin, you'd have to consider inflammatory breast carcinoma as well. Thank you.
Thank you. So an ultrasound guided core biopsy of the right breast mass at 6 o'clock in the left axillary nodes shows grade 3 invasive lobular carcinoma, which, just to point out again, her original tumor was ER/PR positive 13 years ago. Here we're dealing with an invasive lobular cancer that's ER/PR and HER2 negative. Metastatic carcinoma in the left axillary node. And on imaging, there the CT chest, abdomen, and pelvis shows nodular enhancing areas in the right breast with left axillary lymphadenopathy, presumably no distant disease, and genetic testing is negative. So Dr. Morrow, I'll ask you if you could just address the two questions that are posed on this slide.
Sure. So this is a scenario we're seeing with increasing frequency as women treated with breast conservation survive long enough to get new second primary breast cancers. And in this particular case, it's quite clear that this is a second primary breast cancer in the sense that it's different histology than her prior cancer. And it's a very long interval between the two, 13 years. And the markers are different, all of which suggest that this is not a late recurrence of her initial ER positive cancer that selected out a clone of ER negative cells because she was being treated with endocrine therapy. So in that circumstance, drainage across the midline is a very different thing than in the case we discussed previously of a patient who had not had any treatment of her breast and can just be due to altered lymphatics and altered lymphatic drainage rather than being a true metastasis, even though the AJCC still classifies it as metastatic disease. So I think in the absence of evidence of other distant metastases, it is appropriate to treat this patient for cure. Now, one of the things about managing the contralateral axilla is that you really can't ever do sentinel node biopsy over there because you have nowhere to inject your tracer. The tumor is not coming out of the left breast, so that sticking your radioactivity and blue dye into the left breast doesn't necessarily tell you that the node with the metastatic disease is gone. So in cases like this, I mean, I think she's got also unusual an ER/PR negative lobular cancer, which for classic lobular cancers happens only in a couple % of cases. If you look at the lobular variants like pleomorphic lobular carcinoma, they are much more likely to lack hormone receptors. So this is also unusual. So in a sense, it's good from the surgeon's point of view because this patient is going to need chemotherapy. I would give the chemotherapy up front in the neoadjuvant setting. This is locally advanced on that side. And by spending a little time giving chemotherapy, you also allow time for any distant metastases that were not yet evident on her initial scanning to make themselves known before you launch into aggressive surgery. So if she has a good response to the chemotherapy, then my surgical approach to this case would be to do a mastectomy on the right side where the breast cancer is and to do a contralateral axillary dissection. I don't think there's any role for staging. If she truly had a good response to the neoadjuvant chemotherapy, you could remap the right side. We know that redo sentinel node biopsy on that side works. The primary reason I would be doing that would be for local control purposes. Since this woman has already received radiotherapy on the right side, we can perhaps hear from Dr. Shaw about the issue of reirradiation, which might influence that decision. But at this point in time, I think it is reasonable to treat this patient for cure because there's an anatomic reason for her contralateral drainage.
Dr. Shaw?
Yeah, I would agree with Dr. Morrow. I think, from a radiation standpoint, she did have previous radiation 13 years ago, but this is quite an advanced breast cancer. So I would favor neoadjuvant therapy. And then, after surgery, I actually would consider reirradiation to the ipsilateral side. It can be tricky, but it is very feasible to do if someone's got some experience. You really want to make sure you do, even though this was initially a right-sided cancer, I would still do cardiopulmonary sparing techniques given the reirradiation. And then I would retreat the chest, the lymph nodes on that side. And then based on the findings of the left-sided axillary dissection, I may even consider adjuvant radiation to the left axilla. Whether you include the left breast is controversial, but I think given a proven previous history of surgery, which explains that lymphatics, I wouldn't chase the left breast. I would just treat the left axilla in conjunction with the right chest wall and regional nodes.
Would anyone advocate for biopsying the node in the left axilla? I don't think, unless I missed it in the context of the case, there was no mention of that being biopsied. Would it change it?
I think it was biopsied and it was
Okay.
also triple negative.
With triple negative. Okay. So Dr. Hurvitz, as we discussed systemic therapy, it sounds like everyone is very much in favor of this patient receiving treatment. Is this the situation that you would use an anthracycline?
Yeah, so I want to underscore what Dr. Morrow said. It's a very unusual situation to have a grade 3 triple negative lobular carcinoma. And this is a situation where I would make sure I'm trusting the pathology, and I may even send the pathology out for a recheck, especially for HER2, because a significant proportion of pleomorphic lobulars are HER2 amplified. And so assuming that it is indeed triple negative breast cancer, yes, given the fact that this does seem to have inflammatory features and contralateral axillary lymphadenopathy, I think maximally aggressive chemotherapy for curative intent is indicated. But I'm very concerned she already has metastatic disease. She is exceedingly high risk. Lobular carcinomas are infamously non-detectable by imaging. It has to get to this point where you see it on the skin. I've had cases that were just absolutely shocking where patients have with lobular carcinomas that we thought were local. I had one patient who went into renal failure and developed bowel obstruction, and we couldn't find what the source of all of this organ dysfunction was until we went in and biopsied the bowel and the ureters and found lobular carcinoma along the lining. So I would watch her very, very closely. I think she's going to end up, a case like this would end up very high risk for metastatic disease. And the only other thing I would mention about it is next generation sequencing would be called for if she did have metastatic disease to look for PD-L1 expression to determine whether to use immune-based therapy with chemo. And I would also look for a HER2 mutation. HER2 mutations, which are distinguished from amplification, are rare in breast cancers, but can occur in invasive lobular carcinomas. And we are finding through the Summit clinical trial some very nice responses with Neratinib-based therapy. So this is something that might be available to patients with HER2 mutations in the future.
Can you just comment on, in the last moment that we have, on your assay of choice now for PD-L1 testing, given that we don't have atezolizumab available any longer? Are you utilizing the DACO assay for all of your patients for PD-L1 testing?
Yes, we're exclusively testing patients with the CPS or 22C3 antibody now. In some ways, while the withdrawal of the FDA approval for atezolizumab was disappointing for many, it did simplify our lives in that we can now just order the one assay. Before, I think we were in a situation where we had to order 2 assays because there wasn't complete overlap between the 2 assays. And we wanted to make sure we are capturing all patients eligible for immune checkpoint inhibitor therapy. So if I had a patient who's only tested by SP142, I'm now testing by 22C3 to make sure that they're eligible for pembrolizumab.
Great. Thank you so much. And thank you to all of you for the robust discussions around these really interesting cases. I hope the participants and our audience has found it useful. Thank you.